Hello friends, myself Siddharth Chauhan. Welcome to Easy Medicam. So today we are going to discuss about the very important drug which is an anti-anginal drug. So today we are going to discuss about the anti-anginal drug. Today's topic is the anti-anginal drugs. So first, before going to discuss about the drugs or pharmacology of the anti-anginal drugs, first we should have a clear-cut idea about what is angina. So what does actually angina means? What is angina? So the angina is a clinical syndrome resulting from a transient reversible cardiac ischemia. So angina is due to the cardiac ischemia. So we'll define the angina as a clinical syndrome. It is a clinical syndrome resulting from transient cardiac ischemia. So the angina is a clinical syndrome resulting from the transient reversible cardiac ischemia. It is feeling less like a pain but more like a weight. Sometimes felt like a burning sensation also. So the angina is a symptoms of the cardiac ischemia. We can say that it is a symptom of cardiac ischemia. It is a symptom of cardiac ischemia. Second, it may be the pain or it may not be the pain. So we can feel the pain or we cannot. There may be a situation also where we cannot feel a pain also. So it may be pain or may not be pain. Central chest discomfort, pain, just like pressing pain or weight like discomfort, band like discomfort. So these are the some of the symptoms due to the angina. So actually how we feel, the central chest discomfort might be there. Central chest discomfort, pain, just like pressing pain or weight like discomfort. Or band like discomfort. Okay, so these are some of the symptoms of the angina. So we can have a symptoms of cardiac ischemia, it may be the pain or it may not be the pain. Central chest discomfort, pain just like pressing pain or weight like discomfort, band like discomfort. This uncomfortable feeling in the chest may be radiating to one arm or to the both of the arm, to the neck or to the jaw or to the epigastrium or may not radiate at all, or may be felt only in the area of radiation. Okay, the angina is due to the transient reversible cardiac ischemia. We know that it is due to the imbalance between oxygen delivery and oxygen demand. So this is the main point. Why does angina or ischemia occurs? So it is due to the imbalance between oxygen delivery and oxygen demand. Okay, the typically angina should not last more than 20 minutes. This is a caution, so we should take care about this, that angina should not last more than 20 minutes. If it is occurring more than 20 minutes, there might be a chances of myocardial infarction. So the angina should not last more than 20 minutes. Angina should not last more than 20 minutes. Should not last more than 20 minutes. So usually angina lasts somewhere between 15 seconds to 15 minutes. It should not last more than 20 minutes, because if severe chest ischemia lasts more than 20 minutes, then it will lead to a myocardial infarction. And once myocardial cells are getting infracted, it is not angina at all, because angina doesn't lead to death of the myocardial cells. So now uh, we had discussed about the what is angina and what are the symptoms of angina, how it is going to occur. Now let us discuss about the types of angina. Before going to discuss about the pharmacology of the drugs related to the angina, we should cover about what does actually angina means. There are three types of angina. So angina is of three types. One, two, three. So the first one is a classical angina. It is also called as a typical angina, stable angina, or the important one is a exertional angina. So first one is a classical angina. It is also called as a typical angina. It is also called as a stable angina. And it is also called as an exertional angina. This is the first type of angina. The second one is the important one, which usually occurs in the female. This is a prinzmetal angina or the variant angina. Prinzmetals angina. And the other name is the variant angina. This is the second type of angina. And the last is the unstable angina. So these are three types of the angina. First one is a classical, typical, stable or exertional angina. Second one is a prinzmetal angina, and the third one is the unstable angina. First we should discuss about the stable angina. The stable angina, usually these obstructions, it occurs due to the obstruction in the arteries which are supplying the blood to the myocardium. In stable angina, there occurs an obstruction in the arteries which supply oxygen or the blood to the myocardial cells itself. So what are those arteries? We know those arteries. Those arteries are the coronary arteries. So any obstruction in the coronary arteries leads to the stable angina or exertional angina. Okay, so the it obstruction becomes more than 90%, then even the angina occurs at rest also. So might be a, so these are the three types of angina. So first type of angina is a stable angina which occurs due to the obstruction in the coronary arteries due to the thrombus formation or atherosclerosis or atherosclerotic plaque formation. The plaque is not more than 70%, uh, and this type of angina occurs when we are doing the exercise or some other activities. So this is a stable angina. Here we are discussing only the brief discussion about these types of angina. In the later section of the videos, I will discuss about the details of these three types of angina in the uh, different section of the videos of the angina. So because we are discussing about the pharmacology, we are discussing only the brief for this angina types of angina. This is the stable angina, this is prinzmetal, and the unstable angina. So in the stable angina, there is an obstruction in the coronary arteries, and this obstruction leads to the ischemia of the underlying myocardium cells or the tissues. So this is due to the obstruction in the coronary arteries. And usually these obstructions are not more than 70%. Plaque in obstructing 70% of the lumen. रेस्टिंग के टाइम पे तो ब्लड सप्लाई इनफ है, पर अगर मायोकार्डियम एक्स्ट्रा वर्क करेगी तो ब्लड सप्लाई इनफ नहीं होगी. Okay, so in the case of the when where people are doing the exercise, there might be a chances that the oxygen delivery is insufficient and the oxygen demand might be increased. So these demands are not fulfilled by the these ischemic myocardial heart. So the underlying tissue will get ischemic, and the stable angina might be there. Okay, so these are the classical or typical angina. In the case of the prinzmetal angina, here we do not have any obstruction. There is a there occurs a spasm. So this is a spasmodic angina. So and there is no obstruction in the coronary artery, the coronary artery will get spasm. So this is the case of the prinzmetal angina, where we see a spasm. Okay, so in the case of unstable angina, there is a plaque formation, and that plaque is not a stable one, it is an unstable one. In the case of unstable angina, we will get an obstruction as well as spasm are also seen in some cases. So these are three types of the unstable prinzmetal and the stable angina. So the unstable angina, it is a dangerous angina, because if it is not treated well, it can lead to the myocardial infarction or the total myocardial infarction. Here sometimes even these platelets uh, can release a vasospastic element such as a thromboxane A2, and thus there can be a spasm also. So vasospastic elements such as due to this thromboxane A2, there can be a spasm also. This angina does not respond well to taking rest and taking nitrates. So usually the stable angina will get relief. This patient will get relief by taking the nitrates or the other types of beta blockers or calcium channel blockers. But this is not in the case of the unstable angina. This patient will not get relief by taking the rest or nitrates. So by seeing these situations or this scenario, we can predict that this patient is not a patient of the stable angina. This patient is a patient of the unstable angina, and there might be a chances of getting the infraction also, myocardial infraction also. When a patient of angina has taken a tablets of nitrates 3 times within 15 minutes and the pain is not relief, it is an unstable angina and until proven otherwise. So we can predict that, or we can have a clear picture that it is a case of unstable angina and it is not a case of the stable angina. And because we know that the unstable angina is most dangerous of these all types of angina, so we should take necessary steps to for that patients that he will not get an infraction. Okay, so these so till now we had discussed about the types of angina. So now we are going to discuss about the management or how to cure the these types of angina. First one is a stable angina. For the stable angina, here we have to reduce the work of the myocardium. Okay, anyhow, what we are going to do to manage all these situations? Okay, so for this, somehow we have to reduce the workload of the myocardium. uh, if the workload of the myocardium is reduced, so the oxygen demand of the myocardium will get reduced, and those oxygen demand or the delivery which the myocardium is already doing, it might be a sufficient for the rest of the myocardial cells. So the first motto of ours is to reduce the workload of the myocardium. Okay, use those drugs which classically reduce the workload of the myocardium. If we reduce the workload, that will also reduce the oxygen demand. If we have to reduce the oxygen demand so much, it can be becomes equal to the oxygen supply. So we should have a balance between the oxygen delivery and oxygen demand. If the for due any cases or due to the any situations, the oxygen delivery is getting poor, so we should have a demand which can equalize the oxygen delivery. So we had to reduce the workload of the myocardium. The symptoms of angina will get disappear if the delivery of oxygen and demand of oxygen becomes equal. The for this, we have to give a patient with a coronary vasodilators. Okay, so how we can reduce the workload of the myocardium? First, we can reduce the preload on the heart, we can reduce the afterload on the heart, and the most important situation and for the most important one, we can reduce the number of heartbeats or the heart rate also. So these are the three works of the myocardium, that we can reduce the preload, we can reduce the afterload, and we can reduce the heart rate to reduce the workload of the myocardium. So this is a case of the stable angina. For prinzmetal angina, what we have to do? For the prinzmetal angina, first we have to uh, think about that this is due to the vasospasticity. What do you think? Reducing the workload of the heart will help this patient? No. Reducing the workload of the heart will not relieve these patients. So what we have to do? We have to give a patient with a use that drug which usually dilates the coronary artery. Okay, those drugs we have to use in the prinzmetal angina which usually dilate the coronary artery, because here the spasm this is a spasmodic condition, prinzmetal angina. Best drug here is a calcium channel blocker. The best one is a nifedipine. We'll discuss about the pharmacology uh, in the short time. So we can use the nifedipine here. Of course, nitrates can also dilate the coronary arteries. So there should be a combination. We will discuss about the combinations of the anginal drugs also. So this is a case of the prinzmetal angina. The next one is an unstable angina. Only good doctors can manage this unstable angina. Okay, there are four components of this whole game. The first one, what we'll see in this case of the unstable angina. The first one is a erythroma, which is an unstable one. The second one is platelet aggregation. Third one is a fibrin deposition, and the fourth one is the added components of the vasospasm. So these are the four things which we'll see in the unstable angina: erythroma, platelet aggregation, fibrin deposition, and added components of the vasospasm. First, we should give the drug which disperses the platelets from here. In the case of an unstable angina, first we have to remove the platelets which are getting already aggregated there. We have to remove those platelets. For that, we have to give an anti-platelet agents or the anti-thrombin agents. As soon as these patients come, ask him to chew the aspirin. First, we have to give the aspirin to this patient because it will not allow more platelets to stick on the obstructed points. Then we have to reduce the workload of the myocardium, which we already reduced. How to reduce the workload? We have to reduce the preload, we have to reduce the afterload, we have to reduce the number of heart rates, and then give the coronary artery dilators. So this is the case of an unstable angina. We discuss about the management or how to manage the types of angina. We discuss about the stable one, prinzmetal angina, and unstable angina. So I think we are getting an idea about how to cure an angina and what types of angina are there, and what actually the angina means. So we discuss about these situations. In the next section of the video, we'll discuss about the uh, pharmacology or the drugs used in the angina or the anti-anginal pharmacology or drugs. So that's all for today's part of the video. I hope you like the cover of mine. If do so, please like, share and subscribe my channel and press the bell icon for more notification. And please guys do comments also. Thank you.